Hello, everyone. Good evening. My name is Franklin. I'm one of the two co-founders of NorCal SCI, also known as the Northern California Spinal Cord Injury Foundation. Welcome to tonight's presentation on spinal cord injuries and the bladder. I'm very pleased to have an incredibly talented and experienced person who's going to be doing this presentation, Dr. Christopher Elliott. Uh, we're looking forward to a lot of helpful information that he's going to share with you. But a couple of housekeeping items first that I want to get out of the way. So everyone has been muted in order for us to eliminate any kind of background distractions that might come out throughout the evening. So that's why you cannot hear anything other than what myself and Chris are going to be saying. If you have any questions during the presentation, rest assured that there's going to be a healthy amount of time that we have set aside for a Q&A session at the end. So about 15 minutes time that Chris is going to leave for a Q&A session. And so feed your questions to me using the chat feature on your screen, and we'll ask those questions at the end. The second thing is we are recording this presentation, and we will make it available to everyone who has registered for the event. We'll send it to you out by this weekend. And that way, everything that Chris has to share with you, you'll have it should you need to jump off the call or have some other interruption. And Chris has put together an incredibly informative presentation. He's going to go through it rather quickly because we don't want to get sort of too hung up on all the details, but he wants to touch across as many subject matters as possible. Really, the most important part is the Q&A session. And I do want to let you know that ethically, Chris cannot sort of diagnose your specific situation. So he cannot tell you without having seen you, examined you, what your sort of condition is or what your solutions are. He can, however, give you sort of what the options are. And we always recommend that you take those options with your physician, whether it's your primary care physician or your urologist, and discuss those solutions, with that individual. So just want to be clear with everyone that do not expect Chris to literally, tell you what to do. That would be inappropriate for him to do. So now that we got that stuff out of the way, let me go ahead and introduce him. Chris graduated from Ohio State University, receiving both his MD as well as a PhD in epidemiology. He completed his urologic residency at Stanford University Medical Center in 2010. In 2012, Dr. Elliott joined the Division of Urology at Santa Clara Valley Medical Center in San Jose, one of the top rehab hospitals for individuals with spinal cord injury in the country. And he also had a joint appointment at Stanford University Medical Center at the same time. His main academic interests include the epidemiologic study of pelvic organ prolapse, incontinence, and bladder dysfunction after a spinal cord injury. So it is my pleasure to introduce a good friend of NorCal SCI and a very talented and well-educated and experienced urologist, Dr. Chris Elliott.
All right. Well, thank you, Franklin, for the very nice introduction. I'm honored that NorCal SCI would have me back to talk specifically about things that I really care about, which is spinal cord injury and how to manage a bladder in its best way possible. Give me 1 second. All right. Can everyone see my screen okay?
Yes, Chris, you're good.
Okay. Thank you, Franklin. I forgot everyone else is muted. My apologies. Okay, so spinal cord injury in the bladder. Why is the bladder different after an injury? What are your management options, and what to do about those pesky UTIs, which are probably the most bothersome thing that my patients deal with on a regular basis. So a brief outline of our talk. We're going to talk initially about how a bladder functions and the variations after spinal cord injury, what makes it different after an injury. We're going to go very briefly over the available bladder management options that are out there, the pros and the cons of each of these. And then I'm going to try to spend most of my time going over the causes of UTI and how to minimize them, going over antibiotics, a lot of the supplements that are out there, and any of the data that's actually out there to support or refute these practices. So as we all know, spinal cord injury is not all that common. There's only about 17,000 new traumatic spinal cord injuries per year. That means in the whole United States, there's only about 200,000 people with a spinal cord injury. And because of this, good research is hard to come by. There's just not enough people with it for us to do good research, though things are getting better with social media, allowing us to reach out to people more easily. Of those with a traumatic spinal cord injury, 70% are unable to void in the long term. And volitional voiding varies depending on the completeness of injury. So people that are unable to move or feel below their injury almost never volitionally void, whereas those that are able to walk and feel below their injury, even 25% of those are unable to void. So even in the best case scenario, a substantial proportion of people are unable to void. And why is that? Well, let's go through regular coordinated voiding. So what we have here is a brain. I think most of you will recognize the brain and the spinal cord, and then the bladder and urethra below. And what happens is for normal voiding to occur, the bladder as well as the pons, so this part of your brainstem that the arrow is coming from, they have to work in coordination. So the bladder will fill. It will then want to squeeze. The bladder will squeeze. And in addition to the bladder squeezing, the urethra, these sphincter muscles need to open. So you have to have the bladder squeeze, and then you have to have a valve open. And that's two sets of muscles, one squeezing and another relaxing, that have to happen. So it's kind of a complicated coordination process. As an infant, your bladder fills. It checks with the pons up where this black arrow is. And the pons will say, sure, you can squeeze. And at the same time the bladder squeezes, the urethra is told by the brainstem to relax. And that's how you get voluntary voiding. As we get a little farther along in life, the forebrain, so part of our brain, learns to control the pons. So the bladder will fill and it wants to squeeze, but it'll check with the pons. And the pons goes, hey, there's this new guy up here in the brain, and we should check with him. And the brain will say, well, let's not do it right now. We're in the middle of Dr. Elliott's talk. Let's wait until after the talk to urinate. So then the pons will tell the bladder, hey, don't go right now. But 45 minutes from now, you'll go sit on the toilet. The pons will check with the brain again. The brain will say, sure, it's a good time to go. The bladder will squeeze, the urethra will relax, and we get nice coordinated voiding. This can be disrupted during a stroke. So the coordination between the pons and the brain itself is disrupted. And so oftentimes those patients will have trouble postponing voiding, but it'll be coordinated. The bladder will squeeze and the urethra will relax. It just may not happen when the patient wants it to. And this can lead to urge incontinence. After a spinal cord injury, the connections between the bladder and the pons can be disrupted. And what happens in this particular case is there's a lack of coordination. So the bladder will squeeze, but the urethra may not relax. And this can lead to poor emptying. It can also lead to really high pressures, and that's called Detrusor sphincter dysenergia. So instead of normal voiding where the bladder squeezes and the urethra relaxes, instead we get a picture where the bladder starts to squeeze, but the urethra doesn't relax. And this can lead to leakage at inadvertent times, but it also can lead to poor emptying, and it can lead to really high pressures because that muscle starts trying to really overcome that sphincter, and it gets very thick, and the bladder stops stretching so well, and we can generate really high pressures. And that leads to renal deterioration over time. And that's why a substantial portion of patients prior to the 1970s died of renal dysfunction. About 25% of people with spinal cord injury died because we didn't understand how to treat their bladder. We got smarter over time. But in a nutshell, inappropriate bladder management can lead to renal failure, though that's really, really rare now that patients are seeing doctors and we understand what we're talking about. But it can lead to leakage. It can lead to autonomic dysreflexia, which is your body's way of saying something's wrong. It can lead to urinary tract infections, and in rare cases, it can lead to stones. So as we go to ways to manage the bladder when you can't volitionally void, well, you could just leak into diapers. You could have a condom cath. You could have reflex voiding. So you kind of pull a hair on your leg or you scratch your leg, and it can lead to bladder voiding. You can have a Foley catheter through the urethra. You can have a suprapubic tube. You can have a sphincterotomy with a condom catheter to catch the urine. You could do clean intermittent catheterization. There are some reconstructive procedures we can do. I'm not going to go into those tonight because they're more rare. So let's go through these individually. So if you leak into diapers or a condom catheter, what you're really doing is masking potential high pressure voiding. In rare cases, it's okay to do this, but generally it's after seeing me and having urodynamics done in your bladder that shows that you either have a safe emptying mechanism or you don't. And I will say that this is pretty rare that leakage into a diaper or a condom cath is actually okay. There are very few times I tell a patient this is a good long-term option. Here's a gentleman who was doing intermittent catheterization and then just decided to stop because he didn't think it was a great idea for him anymore. He was leaking into diapers for about 5 years. By the time we saw him, you can see the bladder is not round like it should be. It looks almost like a clown hat with pom-poms. And this is one of the worst bladders I've ever seen. He'd done significant structural damage to his bladder. He'd actually lost 25 to 30% of his renal function by the time we saw him. Luckily, we were able to salvage the situation with a surgical reconstruction. But again, this had happened and he didn't even know he'd lost 33% of his renal function before I met him. If we talk about reflex voiding, kind of picking a hair off your leg and making yourself void or scratching your thigh, this rarely works. Number one, it usually doesn't induce a bladder contraction, but there's also safety issues with the coordination. And I've seen this being successful in patients a handful of times in my career. It is not a very common thing. Usually, even people that start doing it short-term start to have problems long-term. I don't recommend this unless you've seen a urologist and they have done studies on your bladder and say it's okay. This is incredibly rare that this works. What about urethral catheters? This is something that many of my patients with spinal cord injury use. There's generally the kind of thought that, well, you could have a catheter through the penis or vagina through the urethra, but this can cause problems when we go through the urethra. Long-term, catheters in there kind of rub and they cause friction injuries. This can lead to erosion. You can see this penis doesn't look quite right. The urethra has been split open by the catheter sawing back and forth long-term. And this will happen long-term in almost any patient with a chronic indwelling catheter through the urethra. And in a woman, it erodes much, much faster. And in a woman, generally, it not only rips through the outer part of the urethra, but it rips that way all the way through to the bladder. And it leads to long-term gravitational incontinence, leakage all the time, which usually requires very significant surgical reconstruction to fix. I don't recommend this in men or women. In women, it becomes problematic very quickly. So that brings us to suprapubic tubes. This is a drawing where you can see the catheter isn't going through the normal urethra. It's actually going to a spot right through the lower abdomen into the bladder. This is a good alternative for patients that can't catheterize themselves. It doesn't cause urethral erosion. It doesn't get in the way of sexual activity. But lots of patients are told by other doctors that it decreases urinary tract infection rates. And I'm here to say it will not decrease your urinary tract infection rate, just to dispel that myth. Then we get to sphincterotomies, which many in the audience may have had. This was more of a historic operation. It's not done so much at this point, but what it is a urologist goes in with a little scope into the bladder and they resect away the prostate and then the part just beyond the prostate where the sphincter is. And obviously we don't do this on women because they can't wear a condom catheter for the chronic leakage that would result. But afterwards, it kind of looks like this. It's a very destructive procedure. We're removing healthy tissue in order to promote leakage. As I said, this was done much more historically and is not done so much now. Number one, it's a permanently disabling procedure. When it works, it's great. But the problem is 50% of patients fail long-term. Either the bladder quits squeezing and the bladder just starts filling and there's poor emptying, or you can get scarring where this operation was done. And then you're actually the bladder's trying to squeeze urine through an even smaller hole. When these fail, men generally are wearing condom catheters and then needing to catheterize at varying intervals throughout the day, or they have a suprapubic and a condom catheter. It's a very not satisfying situation for most patients that fail a sphincterotomy, and it's really hard to fix. So most urologists have gone away from doing this. It's more of a historical operation at this point. And again, it's irreversible. So on to clean intermittent catheterization, which many in the audience might do. It's kind of considered the gold standard for bladder management. You don't have a catheter bag attached to you full of urine all the time. It drains the bladder intermittently, and this avoids high pressures in the bladder. So it's generally associated with very healthy kidneys. We usually don't worry very much about people getting long-term renal dysfunction when they have an intermittent catheter. But CIC can be very difficult. You know, what if your hands don't work well and you lack dexterity and strength? Or what if you're a female and you struggle to access your urethra in a wheelchair and you have to get out to a bed, you know, every 4 hours to catheterize? This can be very time consuming. On average, we did a study last year showing that patients spend approximately 55 minutes per day doing intermittent catheterization, but they only spend 15 minutes a day taking care of an indwelling catheter. And that's why a lot of patients don't like to do intermittent catheterization, because they find it time consuming, and there's a million other things to spend our time on during a day. And then the other downside of a intermittent catheterization fully through the urethra, suprapubic tube, there's always going to be bacteria in the bladder. And this can create problems down the road when we start talking about urinary tract infections, which is the next part of this talk. But as you all know, most of you probably use catheters. You have bacteria in your bladder every single day, I would bet. And most of you don't have a UTI every single day of your life. So this makes it kind of complicating when we're trying to figure out who has a UTI, who doesn't. So a caveat to all studies of urinary tract infection, even in the general population, those without spinal cord injury, UTI studies are very flawed. There's often no culture done in general life. Often bacteria aren't the culprit. There's a number of other things that can lead to UTI type symptoms that are not UTIs, and people are given antibiotics every day for things that are not urinary tract infections, and they generally don't get better with antibiotics. If we look at studies of urinary tract infection in the spinal cord injury population, they're even more flawed. And why is that? It's because it's a really hard diagnosis to make. In non-injured patients, bacteria in the urine is very rare. So if you talk to me, who doesn't have a spinal cord injury, I don't do intermittent catheterization, I don't have a suprapubic tube, bacteria in my urine is very rare. So if I start to have a voiding complaint and people find bacteria in my bladder, well, that's probably the cause. But in the spinal cord injury patients, almost all spinal cord injury patients have bacteria in their bladder at all times. And because of this, we can't rely on bacteria being in the bladder as a diagnosis of a UTI. You have to have symptoms on top of that. So because you always have bacteria in your bladder once you have a spinal cord injury, leukocyte esterase and nitrites, which are common on little dip test sticks, are often positive even if you don't have symptoms. And because of this, I don't recommend home kits to test your urine, and I certainly don't recommend them for surveillance, because you're always going to think you have a urinary tract infection even if you feel fine. This is a very difficult thing, and if you do have symptoms, well, you're going to have a positive test every time, whether you have symptoms or not. And again, this really messes up the diagnosis. And again, symptoms in people with spinal cord injury are not always uniform. Some people have autonomic dysreflexia, some have increasing spasticity, some have worsening urinary incontinence, some have back or abdominal pain, some have foul-smelling urine, which is a very poor predictor of urinary tract infection, because it could just be that you have bacteria, and that bacteria, for whatever reason, is making foul-smelling urine, but it's really not causing any other symptoms. These are hard things for us as doctors and patients to try to figure out what matters and what doesn't. Further, it's been shown that spinal cord injuries themselves are not great predictors of when they have urinary tract infections. This was a study done about 10 years ago that showed that people with spinal cord injury are only right about 66% of the time when they think they have a urinary tract infection. I will say that some people are more reliable than others. Lastly, doctors aren't very good at this either. Some doctors love to give you an antibiotic every single time you show up because they don't know really what else to do. This is your ER physician, sometimes your primary care physician. And even if you talk about doctors that like to study UTIs, well, this was a study of looking at 315 different studies that were out there. We used 11 different definitions of UTIs as doctors. And in fact, in 315 of these studies, or In about half of these studies, we didn't even use a good definition of UTI. So we don't even know how to diagnose it very well. So we're not very good at it. Patients aren't very good at it. It's a very difficult problem. But if we go to just symptomatic UTI, the most common problem seen in the first year after spinal cord injury diagnosis is urinary tract infection, and about a third of patients will get one in that first year. Of patients in their first year after a spinal cord injury, 42% are readmitted to a hospital, and the most common reason for readmission in that first year is urinary tract infection. So it's a huge problem for patients with spinal cord injury. And it's estimated in the normal spinal cord injury patient, there are approximately 2.5 symptomatic UTIs that are treated per year. And this is a number I freely give to patients, saying, I expect you to get 1 to 2 to 3 infections per year. And sometimes that's the cost of business that we have to deal with bladders that don't work correctly. And that's hard to tell people because that's not what they want to hear, but it's reality. But what are the risk factors for urinary tract infection in those with spinal cord injury? Well, bacteria being in the bladder all the time is clearly a risk because the bacteria in the urine can cause a urinary tract infection. But if you look at patients that have indwelling catheters, once you've had that catheter in for more than 2 weeks, 100% of people have some bacteria in their bladder. Those that void without instrumentation, those that don't do CIC, don't have indwelling catheters, well, they have the lowest risk of UTI or lowest risk of bacteria in the bladder. And if you look at it from a schematic standpoint, those with suprapubics and indwellings almost always have bacteria in the bladder. Those doing intermittent catheterization are in between, but I would tell you that they almost always have bacteria in the bladder. Those with condom catheters or who volitionally void have the lowest risk of bacteria in the bladder, but that's a very rare subset of people with spinal cord injury that can get away with a condom catheter or can volitionally void. Most of you are probably in the suprapubic tube or the intermittent catheter group where we're almost always expecting bacteria in the bladder. But it's interesting, lots of people have bacteria in the bladder, but not everyone gets a UTI. There are many patients that I take care of that have 1 UTI a year, 0 UTIs per year. You know, what's the difference? And that is kind of the next part of the talk. What are the other risk factors? Well, high bladder pressures are probably one of the biggest, and I'll kind of go through that in a second. There's also probably an individual susceptibility. One patient's risk is not another patient's risk. And then there's also the type of bacteria one is colonized with. Some types of bacteria may be more beneficial or more protective than others. So again, risk factors for UTI, when we're talking about increased bladder pressures, well, this may mean that you're not cathing enough because higher bladder volumes equal higher pressures in the bladder. And pressure, as you can imagine, it just pushes bacteria into the wall of the bladder where it can start to cause problems. Not being on an anticholinergic like oxybutynin or a beta-3 agonist like mirbetriq, well, that can cause you to have increased bladder pressures, but not everyone needs those medications for sure. And incontinence is a nice surrogate. If you're leaking multiple times per day, well, that's usually a sign that there are increased bladder pressures multiple times throughout the day. And if we can get rid of incontinence, oftentimes we can get rid of UTIs. So this was a study looking at Botox. You know, Botox is a medicine to decrease bladder pressures. It does not have any antibacterial effects. But in this small study of 30 patients with spinal cord injury, pre-Botox, they were getting approximately 2 infections every 6 months. Afterwards, when they stopped leaking, most of these patients, their infections went down to 0.2 infections per 6 months. This is a huge decrease in leakage. And of those that got an infection after Botox, it was the 3 that had the least improvement in their leakage that actually had the greatest chance of a UTI. So again, this kind of suggests that it's not always the bacteria, it's other factors plus the bacteria. So if we can bring down bladder pressures with medicines or Botox, we can often fix problems with UTIs. So when I have a patient come see me for recurrent UTIs, the first step is figure out what they've been infected with. Is it the same bacteria over and over and over again? Or is it a different bacteria every single time? Because that can kind of help me figure out what the problem is. So getting urine cultures every time you have a UTI before you get treated is actually really helpful down the road, if you continue to have problems and you see me, it helps me put you in a proper frame of mind as I start to work it up. If it's persistent, the same bacteria over and over again, let's try to find a source. If it's new bacteria every single time, well, is there something in your regimen that we need to modify? So when we have persistence, same bacteria over and over and over again, I usually try to get either an ultrasound, a CT scan, even a plain x-ray to figure out maybe there's a stone. I sometimes look in your bladder with a scope, not often. Sometimes I get urodynamics, have you come into the clinic and we see what your bladder pressures are. Sometimes we get a voiding or a cath diary, see how large your volumes of urine are, because that can be a clue as to what the problem is. Here's a patient. A simple x-ray proved what the problem was. As you can see, maybe, there's a very large kidney stone in their left kidney. This is causing the recurrent infections that they're having. Here's another patient. I think you can see the problem down in the bladder. They have a huge bladder stone. That's the cause of their problem. And that's why they're having leakage and being treated with infections all the time. Their bladder is completely full of a giant stone. Here are more stones seen cystoscopically on a patient where I had to go in, I looked and I said, oh, you have all these stones in your bladder. They're probably irritating your bladder and causing you to leak. The infections aren't really infections. Maybe it's just these stones irritating your bladder. Here's another patient where we got a cath diary. And as you can see, 500 cc's is probably the most I tell most people to try to hold, 500-600. Well, here's a patient getting up to 1,000, 1,400, 1,600 cc's per cath. They're drinking so much water because someone told them to drink a lot of water to prevent UTIs. But really what this is doing is overpressurizing their bladder. This overdistension and overpressurizing is exacerbating their UTI problem, not making it better. We fixed this patient just by changing the amount of fluid they were drinking. Seems silly, but it actually worked. Here's another patient where we did urodynamics because I couldn't figure out what's going on. And not to bore you with a physiology lesson, but essentially this patient started to tell me, yeah, that's the pain I'm having when I have a UTI. I was able to reproduce it in the lab. Well, what was really happening was his bladder was squeezing like crazy. So it's really, this patient just needed anticholinergics and a beta-3 agonist to get their bladder to calm down. Their overactivity went away, their pain symptoms went away, and their thought of having a UTI went away. So again, what we perceive as a UTI is not always a UTI. So like I said, common confusing conditions are bladder stones, bladder contractions or leakage, autonomic dysreflexia, which is often a reaction to bladder contractions, nerve-related pain in the body, constipation can lead to symptoms of a UTI, which is not always a UTI, dehydration, drinking too much fluid, as I suggested. So let's go to treatments because that's what you're all interested in. Lots of people want to know if they have an indwelling catheter and they irrigate with saline every day, will that help with UTIs? Well, it's not been shown to decrease bacterial counts in the bladder, and it hasn't really been shown to fix UTIs. Daily irrigation with acetic acid or geoirrigant or renicidin doesn't really seem to affect bacterial colony counts. And while geoirrigant is successful in some of my patients, it doesn't help everyone. Telling patients to increase their urine production, that doesn't seem to decrease bacterial counts and doesn't seem to affect urinary tract infections. Trying to be super fastidious about keeping yourself clean or constantly changing indwelling tubes, that has not been shown to decrease bacterial counts either, and it has not been shown to help urinary tract infections. I tell most of my patients that do intermittent catheterization, I don't think you need to go through a crazy regimen of gloves and sterilizing the urethra with antiseptic ahead of time. I don't think that really works. I have some people who anecdotally tell me it works great. I'm all for them continuing this practice, but I'm also not for the practice of people doing it just because they think it'll help with urinary tract infections when they find in their own mind that it really doesn't work. It doesn't work for everyone. Antibiotic prophylaxis. This is taking antibiotics every single night. In the short term, this can decrease symptomatic UTIs in people with spinal cord injury. The problem is long-term problems can occur. You can get side effects of taking antibiotics for every day for the rest of your life. You can get resistance of the bacteria to those antibiotics. So future infections are then resistant to antibiotics. And then often once the antibiotic stops, the protective effects goes away. So being on it for a short course and then stopping, it doesn't decrease your chance of a UTI in the future. And then when I talk about, medicines that people take every day, well, nitrofurantoin or macrobid, well, that can cause irreversible pulmonary fibrosis in about 1 out of 750 patients that take this. That could be really, really bad. I don't know if that's worth it because that's an irreversible problem. It scares me. Septra or sulfamethohexazole, that can cause drug reaction. In rare cases, it can cause a Stevens-Johnson syndrome, which is like a scalded skin that I've actually seen kill a patient once. It can also interfere with the metabolism of other medicines that you're on, like Coumadin and things like that, blood thinners. When we get to antibiotic-coated catheters, they work for about a week, and then they don't help afterwards, so they're not recommended for use. Catheters coated in silver. No one's ever been able to show that these work, even though silver kills bacteria. It exerts its effect over a very short time period and is not good long-term. Hydrophilic catheters, catheters that come like pre-lubricated compared to just putting lubrication on the catheter. Well, in a few studies, UTIs are decreased at 3 months in their trials, but at 6 months, these benefits aren't seen in some of the same trials. And if you look, out of the 5 trials that I know of, 4 have shown no benefit of these types of catheters, even though they're pushed very highly by the catheter companies. Methenamine is another thing that's out there. It's a non-antibiotic prophylactic strategy. Essentially, in acidic urine, the drug is turned into formaldehyde, which can kill bacteria. The problem is, in the studies I've seen of methenamine, it doesn't work very well. It works about the same as placebo or cranberry pills. And I have a few patients that this works really well for, and I prescribed it to people before, hoping it might help. But when it doesn't work, I don't tell people that they're doing it wrong. It's probably just, it doesn't work for everyone. Cranberry, which a lot of people are very interested in. This is thought to decrease the binding of E. coli and Pseudomonas to uroepithelial cells, so it keeps them from sticking to the bladder or the urethra. The problem is E. coli and Pseudomonas are not the only things people with spinal cord injury get that cause urinary tract infections, so this doesn't always work. And the effect of cranberry juice they're considered to be moderate at best in people without spinal cord injury. It's not really accepted as the greatest thing ever. And in people with a spinal cord injury, there's no effect that's ever been shown for a cranberry supplement or cranberry juice that's been noted. That's just the data. And again, the tablets are poorly studied due to differing mixtures and standardization. But more recently, a company came out with a drug called Allura. This is something that's much more standardized. They've actually isolated the part of cranberry that was thought or is thought to decrease urinary tract infections, and that's the procyanothiodine. And you can buy this over the counter or through Amazon. There's one study that exists in the spinal cord injury population. It was 13 patients, all male, all doing intermittent catheterization. They had to have bacteria in their bladder at inclusion, and they followed them up for 2 weeks. But what they found is at 2 weeks, there was no difference in bacterial levels. There were no difference in urine white blood cells. And more importantly, they asked patients, did you see a difference in your urine clarity, odor, color, sediment? And no one found a difference compared to placebo. So I take this to be, the data doesn't really support their use. Allura is a little bit expensive. So I tell people, if you want to try it, that's fine. But don't stay on this medicine that's super expensive if you don't find it's working. I would give it a good, couple month trial period. If it doesn't work, don't waste your money because the data doesn't substantiate it, despite what the website might tell you. Here's another one that's been promoted quite aggressively over the years. This is D-mannose. It's again thought to inhibit binding of bacteria to uroepithelial cells, specifically E. coli, which obviously is not the only cause of urinary tract infection in spinal cord injury patients. There's one clinical trial done to date, which is successful, and this was in women in Bosnia. they showed it worked remarkably well. It actually even worked better than antibiotics. But I have questions about this. I've never seen a confirmatory trial. I've never seen it tested in a spinal cord injury population, and I'm not sure it really works. That being said, it's not super expensive, and I have patients who have gone to the GNC store, bought this over the counter because it's just a sugar, essentially. That's what mannose is. I tell people to try it. If it works over 2 or 3 months, then keep doing it. If you find it doesn't work, well, then don't waste your money. People have tried to crowd out bad bacteria with good bacteria. These were several studies done at the VA earlier in the 2000s. They basically got an virulent strain of E. coli and tried to put it in bladders. It was really hard for this to be done. They had to put people on large courses of antibiotics to get rid of the bad bacteria before they could put the new bacteria in. And they found, despite this very, very complicated algorithm, that only 25% of patients could even get the good bacteria to stay in their bladder. And even when it happened, they couldn't get the bacteria to stay more than 3 or 4 months. And they didn't ever follow up on this to any great degree. There have been people talking about trying to coat catheters with these bacteria to maintain colonization. To date, that hasn't been done and it hasn't been successful. Certainly something to consider in the future, but I've yet to see anybody able to do it. So in the end, not a lot of great treatments exist. And I'm sorry to say that because I know everybody wants something to fix this. But I would say it's not all doom and gloom. UTIs are generally treatable. They're not overwhelmingly common, though I do expect patients to get a couple UTIs per year. Like I said, some get more, some get none. If you have more than 4 per year, I think a urologic consultation is important. Sometimes there's an underlying condition to blame, which is not a bacteria problem, but rather it's a bladder problem or a drinking problem or not cathing enough, or your catheter regimen is not good, or you have a stone, or there's some other underlying condition that can be confused with UTI. We can figure this out pretty readily with a pretty standard algorithm. My pearls are, don't treat your urine just because it's cloudy. Lots of people have cloudy urine. If they drink a little more fluid, it goes away. I hear this time and time again, that just drinking extra fluid makes this better. Don't treat your urine just because it smells. Again, drinking more fluid often gets rid of the smell. I would treat if you have cloudy urine, smelly urine, and you have new onset incontinence. If you have a new onset fever, if you feel really lousy, of course you should take antibiotics. Please don't let us get in the way, and don't misunderstand my talk. And I would say just because certain treatments don't work for the population at large doesn't mean I won't try them. I prescribe G-Irrigant. I prescribe methenamine with vitamin C to acidify the urine. I prescribe prophylactic antibiotics at times. I do tell patients to try cranberry tablets or Allura if they want. And I also tell people to try D-mannose if it's something they want to try. Again, as long as it doesn't break the bank, I feel like you have very little to lose. But again, a lot of these things towards the end are not covered by insurance. Again, I also have people that want to try probiotics. I got nothing against it. If it makes it better, great. If it doesn't, well, then let's stop and set yourself up with a time period where you're going to test it like 3 months. That works great. And lastly, I'm always willing to admit that I might be wrong about something. Medicine's more of an art than a science. And I learn a bit more each and every day, and my practice is ever changing. Most of what I do is not in a book. It's what I've learned from patients with spinal cord injury. They, do me the honor of coming to see me every day in my clinics and teaching me about what I know or don't know. And we try things together and we learn what works and what doesn't work. And lastly, and most importantly, I consider it an honor to have so many patients that trust my opinion. I know many of you are on the talk tonight. I really appreciate that I have so many patients that really believe in what I say and consider me to be an expert in my field. And I'd like to stop with that. Obviously, some of you also know that Travis Roy, a spinal cord injury patient who did a lot of great things for spinal cord injury, he actually just died today at the age of 45. It's a very sad story. He, in his first college hockey game, he broke his neck 11 seconds in, became quadriplegic. But instead of letting that be a downer. He turned his life, he turned it into something else other than what he probably intended, and raised lots of money for spinal cord injury research and to help spinal cord injury patients. I think we should all try to live up, at least for a day, to the example that he set for us. But anyway, at that point, I am done, and I am happy to take questions.
Great. Thanks so much, Chris. Wow. I obviously had the opportunity of seeing your presentation last night. I thought it was incredible, but just hearing you deliver it, I had a big smirk on my face because of just the incredible wealth of information that you shared, and how real it is. And I know it's frustrating for the spinal cord injury community to believe, or to hear some of the realities. And like you said, because of the lack of research, we're sort of oftentimes going off of anecdotal sort of experiences. And at the end of the day, sort of research prevails, people. But like Chris said, he's not going to get in your way to try any of those sort of approaches that he shared with you. So, Chris, we have a number of questions. Let me ask the first one. At
Absolutely.
what point should someone say, okay, I've had these symptoms of the foul smell, the cloudy urine, and fever? How many days or how much time should they allow for those things to potentially work themselves through before they say, all right, I better go see someone?
Yeah, I think that's a really individualized question. Again, the cloudy urine, the smelly urine, I think you've got time to let that sit for, days, even a week, while you try to just see if it'll go away with increased hydration. But I would say if you start to have leakage that's you never leak in a day in your life, and all of a sudden you're leaking, you should probably go get treated, because it's real, right? If you start to have horrible spasms and you've never had a spasm a day in your life, or you have spasms sometimes, but your spasms are out of control, well, you should probably get treated, right? If you have a fever, I would say you need treated immediately. Like, that's not just a simple UTI. That's what we call a complicated UTI. You have a fever and your body is getting sick, and that fever may be the first sign that you're about to need to go into the hospital, because you're going to get really sick. So fevers are not to be ignored at all. I don't say, oh, you should just try to make it better if you have a fever. If you have a fever, you should be seeing a doctor immediately for antibiotics, even potentially going to an urgent care and an emergency room, and in rare cases, needing to be admitted, because you may get even more sick. So I just want to make sure that's clear. I'm not advocating ignoring signs, but I also would say if it's just cloudy urine, just smelly urine, I would give it days to a week to try to get rid of it if you can. And then, those are often the patients that are very successful with things like geo-irrigant, or drinking more fluid, or trying Allura or something like that. It kind of breaks whatever cycle is just beginning and gets rid of it. But I don't have great data to suggest, what's better or what's not. I try to avoid antibiotics because I want them when people get really sick with that fever. But there's a time and a place, and especially the people with, spinal cord injury for many, many years, they tend to know their body even better than I can. So I can have all the data in the world, but it's up to, a lot of times I will cede to, fine, you complain about a UTI once a year. You think it's bad now, you better treat it. You know what you're doing.
Okay, very good. What are the consequences of repetitive antibiotic treatments?
Yeah. So, for the most part, antibiotics are not the worst things in the world. And I'm not trying to say that, but, the worst thing is people get put on multiple courses of antibiotics for, just cloudy urine. And then all of a sudden they get some horrible diarrhea. They get a Clostridium difficile infection, which is a bacteria that can, a bad bacteria that can kind of generate when lots of other bacteria in the GI system, the gastrointestinal system, are killed off by antibiotics. Those are really bad things, because uncontrolled fecal incontinence is even worse than uncontrolled urinary incontinence for patients, just because of what it can do to the skin. So those are things that can happen. You take antibiotics every day of your life, or you're on antibiotics 10 courses in the course of a year, there may be a time at some point where you actually get a real infection, and we don't have anything more by mouth to treat you with, and you have to come into the hospital for IV antibiotics, or goodness forbid, we get to a point where there's nothing even left IV, and then we're in real trouble. And that's a growing reality in this country as well as other countries, as we use antibiotics as much as we have. Antibiotics have only been around for about 60 years, and we have some bacteria that are now resistant to 10, 11 different antibiotics. It's a scary situation that's coming about. And, while spinal cord injury are not to blame, we're also, our treatment of the spinal cord injury population is not helping the situation. We give, I think, too many antibiotics.
Okay, fair enough. All right, next question. Is chronic prostatitis related to frequent UTIs?
I don't know. I'm not sure chronic prostatitis is even a thing. I don't know exactly what that means, because urologists use that as kind of a garbage bag term sometimes. Sometimes chronic prostatitis just means UTIs. Sometimes it means pelvic pain. Sometimes it means something I don't even understand. So I don't really know what chronic prostatitis is. I would say UTIs are UTIs, and whether you have an infection of the bladder or the prostate, which essentially touches the bladder, they're the same thing in my mind.
Okay. Next question. Has phage therapy been used successfully for treating UTIs?
It's an experimental process right now. I have not seen data to give me any hope that it's on the horizon or going to fix anything anytime soon. But like you all, I'm certainly hopeful that we can find things. We can mutate the coronavirus to kill all the UTIs. That would be awesome.
Great. Why is it that with suprapubic catheters, the risks and chances of infection, UTIs, remain when there is no sort of external intervention?
So, as I see it, the catheters are just a conduit for bacteria to kind of crawl down. So once you have an indwelling catheter all the time, the bacteria just work their way down the little tract, either through the urethra or down the suprapubic tract, and colonize the bladder. It's kind of the same way, how did bacteria get in my ear? Well, they just kind of work their way along the skin, and, now my ear has bacteria in it, but that doesn't mean I have an infection in my ear all the time. I don't have an ear infection every day of my life. I don't have a nose infection, but there's bacteria all over these orifices that are connected to the air and the skin.
All right. Next question. You addressed this briefly about probiotics, but this person is asking about administering probiotics directly into the bladder to prevent UTIs.
Yeah, I haven't seen that. Most probiotics are essentially just trying to make the gut flora, so your gastrointestinal system, you're trying to bring good bacteria into the gut, which is generally the source of most urinary tract infections. They're usually E. coli or Klebsiella, all things that are found in your intestines and stomach and things like that. So we're trying to outcompete those with good bacteria. I haven't seen any studies trying to put probiotics directly into the bladder, other than those VA studies where they were trying to take a form of E. coli that was non-virulent and trying to replace it. But like I said, they could never really get those bacteria to stay there very long. They eventually just got outcompeted by normal bacteria. So it hasn't been successful to date. And that's the closest thing I know to probiotics in the bladder.
Okay. What can you tell us about the benefit of getting a regular urodynamic study conducted?
So I may not be the best person to answer this, because I'm kind of a minimalist about a lot of things I do. I tend to try to get a urodynamics on most people 4 to 12 months after their injury. I get an idea of what the patterns are, and I get an idea, maybe things down the road that may be a problem or not. I typically do not get further urodynamics unless things drastically change away from where I think they should be over time. So I tend to get one urodynamics, and then I don't really get another one unless something weird is going on. I do tend to try to see patients on a regular yearly basis at minimum to get ultrasounds, make sure they're not developing stones or other problems. And honestly, usually just talking to patients, I can get a pretty good idea of what's going on without a bunch of fancy tests. It's amazing what low tech and just talking to patients will get you. I can usually get a better story than doing a fancy expensive test and not talking to patients. I get more by talking to people.
Great. You had a slide that sort of talked about this person that was drinking a ton of fluids. How do you balance, because on one hand, some physicians say, keep yourself hydrated, drink a lot of fluids. And then, there was your slide, but how do you balance those two? Yeah. What do you tell patients?
So there's a way to not drink enough. So drink so little that you put yourself at risk for kidney stones and bladder stones and things like that. there's drinking way too much, which I showed in that one slide. What's the middle ground? I tell most people between 2 and 3 liters per day. So 2,000 cc's of urine to 3,000 cc's of urine per day. 2,000 is a little easier for a lot of patients, because if you're going to get out 400 or 500 cc's, well, then you're down to 5 catheterizations per day on CIC. If you get up to 3,000, well, then you have to add another cath or two to the day. That's the consequence of drinking fluid is, if I drink a lot more fluid, well, I have to go pee a lot more. And that's the consequence of that for people with intermittent catheterization. For those that have Foley's or, suprapubic tubes, I think you can probably drink as much as you want, as long as you don't throw your electrolytes out of balance. So I have some people that drink 3 or 4 liters a day, and they're perfectly happy. They're not getting low sodium levels on that, and they do fine. And I think that's fine. So I think it depends a little bit on bladder management. And I also think it just depends on the patient. But generally, 2 to 3 liters a day is a good measurement stick to go by.
Okay. You talked about this next question briefly, again, in terms of the types of catheters and their effectiveness. But this person wants to know if you've seen any research or any difference in terms of using latex versus rubber catheters, silicone, and anti-infection sort of silicone catheters.
Yeah. So it's a good question. And for the most part, no. I tell people, use what you like. I don't think there's any difference between any of them. And the catheter companies would have a fit to hear me say that, but I don't think it matters. I even don't think reusing catheters is a bad thing, as long as you somewhat clean them between uses. I really feel like soap and water probably works just fine. And there's some people in the audience who probably gasp and think I'm a horrible person by saying that, but there's really no data to suggest that it's any worse. It's called clean intermittent catheterization, not sterile intermittent catheterization. And for 30 years before 2007, most people were reusing their catheters, and no one was dying right and left that I know of. And I don't think UTIs have changed one little bit since we've started giving people a new catheter each time. It's a lot more convenient to have a new catheter each time, and I don't disagree with that, but I don't know from an infection standpoint there's anything better or worse. As far as different types of catheters, latex versus silicone versus something else, I don't think there are huge differences. Most people that are doing intermittent catheterization, they never get a latex catheter because the spina bifida population is allergic to latex. About 15% can have horrible, deathly reactions. So I don't think I've ever seen an intermittent catheterization made of latex because of the danger. As to silicone versus PVC, I don't think there's any real difference. There's no difference environmentally. There's no difference that I know of in terms of UTI health. And there's really no difference in terms of how people do. I think they do well with what they do well with, and I'm happy with that. As long as people are willing to cath, I'm pretty happy.
Okay. All right, next question. My 8-year-old daughter has an L2 spinal cord injury and does ICP. She had a urodynamics test recently. The test filled her bladder to 425 milliliters and showed no leaking, good bladder shape, tight sphincter, and no kidney damage. Ultrasound was done and no reflux, but it did show some increased pressure at least twice during the test. Possible medication was recommended. Should urodynamics be done every year, and can her pressure go down with medications? Also, since she's so young and cathing, what should we watch out for to avoid trauma to her urethra?
So right now, it sounds like she's doing very well. She's not leaking. I assume in real life, she's doing fine. The pressures that we sometimes find on urodynamics, sometimes that's just because we're filling people really fast. We fill people on urodynamics much faster than they fill in real life, because we don't want to sit there for 3 hours watching their bladder fill during a test. So sometimes the bladder pressures we see can be a little artifactual, and we can induce them way earlier. My overall thought would be, yeah, being on a medication to relax your bladder usually is not a bad thing. If anything, it promotes continence, it usually decreases UTIs, and it can keep the bladder healthier long term. In terms of things I would change, I don't think I would change anything if your daughter's doing well. It sounds like she's already got most of the basics down, and she's, got what sounds like on that urodynamics holding 400 at her age is excellent. That's a very good capacity for an 8-year-old. So I see nothing that I would worry about. Should you get urodynamics on a yearly basis? I don't know. You could probably space it out every 2 or 3 years. You could probably space it out indefinitely if she's doing really well and there's no issues. No, I don't usually make huge decisions based on urodynamics unless there's an underlying problem that's bothering the patient, or I see something on imaging that bothers me. I don't make decisions usually just based on urodynamics alone. So again, I'm kind of a minimalist though. So her doctor may not totally agree with that.
Okay. Next question. I've had a suprapubic for 13 years with very few treated UTIs. I plan on getting a mitral FANF procedure. Will this increase my likelihood of getting UTIs?
Usually not. Usually when a mitral FANF is done, a bladder augmentation is done to relax pressures. So generally the pressures aren't high. Could it increase infection? Yeah, it could, especially in the first year or so after a reconstruction. It's one of those things that I don't think we can predict very well. So we would just see what happened. And if infections started to occur, well, we would figure out what the problem is. Because like I said, most of the time, it's not just the bacteria, it's the bacteria plus another factor. And we would just have to figure out what those factors are. But I would not tell most patients going from a suprapubic to a reconstructive procedure that I expect any more infections. But again, it's one of those things that until you live through it and see what happens, I don't know.
What percentage of people opt for that procedure?
For a mitral FANF and an augment, very few actually. Most spinal cord injury patients are trying to avoid surgery, and a lot of them don't want to do anything that's permanent. That's why a lot like intermittent catheterization. That's why a lot like suprapubic tubes. It can be undone fairly readily. An augment and a mitral FANF is a little more permanent. They can be undone, but it's a little more invasive to do. But an augment and a mitral FANF together can give people, if you look at a female that's taking 20 minutes a day to catheterize because they have to get out of their chair, transfer to a bed, lay down, catheterize, get back in their chair. They're doing that 6 times a day. That's 2 hours a day devoted to bladder management. Whereas if they had a mitral FANF, they lift up their shirt, catheterize, they're done in 2-3 minutes. You can cut their time from 2 hours a day down to 20-25 minutes a day for bladder. That's a huge time savings for people, and that's a good reason to do it. It's a quality of life issue more than a decrease your UTI issue.
Okay, very good. Any recommendations for GOOPS? GOOPS.
I don't know what GOOPS is. Can I get a little more information? I'd love to know. I'm going to write it down to look up, but I don't know the answer.
Me neither. Maybe this was a typo. Okay, next question. Is it normal to see a reduction of bladder capacity as you get years out from injury? I've also noticed my penis retracts when my bladder is full or when catheterizing, and a reduction in ability to achieve a reflexive erection. Can a lower lumbar or a S1 joint nerve issue exacerbate this?
Okay, so a loaded question. Let's go one at a time. So can bladder capacity decrease over time? Absolutely. This is why staying in touch with your urologist over the years can help. A lot of times people will get a lot of squeezing of their bladder, but they don't actually leak because their sphincter will stay tight, like I was explaining. Over time, that squeezing all the time, it's like doing bicep curls every single day. Pretty soon, your arm's going to be very strong. The more your bladder squeezes, the more thick it gets and the less storage capacity you will get over time. So that can absolutely, that's why we oftentimes will put people on oxybutynin and myrbetriq before they start to have big problems, because we can make that less of an effect. So yes, I see people that are 15 years out that all of a sudden start to have infections, start to have incontinence, and that's because of that phenomena. And generally we will start medications or we'll go to Botox or we'll do something because it's just wear and tear over the time on the bladder. Okay. And sometimes it's silent. Number two, in terms of erections over time, I think as all men age, if you look at the population, erection potential goes down over time. Can a spinal cord injury lead to decreased erections? Absolutely. If you look at young men who have spinal cord injuries versus young men who don't, the young men with spinal cord injuries are much more likely to be on Viagra or need something to enhance erections. We do have pills, we have injections, we even have, biomechanical devices to give people erections. That's something to talk to a urologist about. But certainly a spinal cord injury can lead to that. Age can lead to that on top of that. So yeah, it's almost like a double insult. You get it, you're a spinal cord injury and you're getting older.
And then the catheterization, that's what he was asking. With sort of constant catheterization, I assume it's ICP, that could lead to loss of ability for loss of erection?
I would say absolutely not, actually. Intermittent catheterization should not lead to decreases in erection. Though the distance between the urethra and the erectile bodies, they're not connected. They're like a surgical mile away from each other. Those are two separate processes. One should not affect the other.
Okay, alrighty. Any recommendations for bacteria with sediment that clogs the catheter? Irrigation helps a little bit, but any other?
Yeah, so when we start to have problems with catheters getting blocked up, especially suprapubic tubes, I like to do renicidin. It doesn't really affect UTIs, but it can definitely affect catheter clogging with material that builds up on the catheters over time. It can be a real problem for some of the chronic indwelling catheter population. We generally will consider 30 cc's of renicidin, and we leave that in there for about 30 minutes and can sometimes dissolve some of those sediments that can cause problems. It doesn't work in everyone, but it's certainly something to try. But it's something to do with a urologist, because you want to make sure it doesn't exacerbate autonomic dysreflexia, because sometimes putting 30, 40 cc's in the bladder is too much and we have to do smaller amounts. And sometimes it really doesn't work. But when people start to have a lot of incrustation of their catheters, we want to look for bacteria that could cause that. That's generally Proteus. It can really rapidly affect those catheters. And sometimes a good course of antibiotics will actually fix that problem. But when it's kind of more just kind of happening from time to time, renicidin can help, but it has to be prescribed by a doctor.
Okay. This next person is asking if drinking more water upon sort of experiencing the mild symptoms of a UTI, if that could potentially help with.
Yes. I think, dilution can certainly help with these problems. And again, I have lots of patients that say, yeah, I thought I was getting a UTI and I drank a little bit more and it went away. That cloudy malodorous urine just went away and I didn't need antibiotics. But it usually takes seeing me to convince them, and then they try it once or twice, and some it works really well. I've had other people say, well, I did what you said and then I got a fever and I ended up in the hospital. Thanks a lot, Dr. Elliott. Well, it's because I'm not perfect and I don't have a crystal ball, but for the most part, I think it works for most people, but it doesn't work for everyone.
Okay. Alrighty. This next question is from someone that I know very well, and he keeps trying to trip me up with using fancy words. So I'm going to give it a shot here. It says, what about a potential link between the single nucleotide polymorphisms of toll-like receptors and increased risk of urinary tract infection? I sure hope you know more about that than I do.
Yeah, I mean, toll-like receptors, I think, are what the bacteria bind to. And I'm sure there are various individuals that have variations in their receptors on their urothelium. So this is just things that sit on the outside coating of the bladder that probably are more susceptible to bacteria attaching to them or invading them than other people. I'm sure that exists because we have some patients that have the exact same regimen and they do terrible, and some that do really well. I have some patients that don't take care of their bladder at all, and others that are super fastidious, and yet the people that don't care at all are doing fine, and the ones who are super fastidious aren't. So absolutely, there's a genetic predisposition, but I don't think we're far enough in understanding genetic footprints to be able to characterize someone's risk or be able to change them, change what they have.
Okay. Next question. D-Manos has worked well for my daughter as she uses it on and off, or is continued use okay? I know you mentioned that there's been no study virtually other than the one in Serbia or something like that.
It was Bosnia, I think.
Bosnia,
but I tell people to do what works. If they find that taking it every day works for them, that's fine. If they feel like using it episodically when they start to get that smelly, cloudy urine makes it seem to go away, I'm fine with that too. I don't have data to suggest one is better than another. I don't even have data to suggest it works, but I do know anecdotally that it does work for some people. And if it works for your daughter, I would do what works. Again, I don't have strong recommendations one way or the other.
Okay. What about a prophylactic bladder irrigation daily with gentamicin? Better than oral antibiotics?
I tend to like that because it generally does not breed resistance in nearly the same way. Like I said, most of the things that cause our UTIs come from our stomach, intestines, things like that. If you're using local either geoirrigant or using local gentamicin washes, you're not causing that. So those are much safer in terms of not developing antibiotic resistance. So I'm a big fan of them if they work. Gentamicin can be a little difficult to deal with because you have to keep it refrigerated and only lasts for about 2 weeks, and you have to get it made up at a pharmacy. That being said, I do have some patients that have done it. I have some patients with symptomatic UTIs that we've actually done that for them, trying to keep them out of the hospital, and it's worked very well. So I'm a big fan of it. University of Michigan has done a couple studies, or done one study where they think it works a little bit. I did not put that in the talk just because the data is a little wishy-washy, but I do believe those things do work from time to time, and I'm all for them if patients are using them and having good success. Again, I'm never going to stop something that works for a patient unless I think it's dangerous.
Okay. Chris, I think you're going to break the world record for the most number of questions asked during one of our presentations. And
that's great.
We still have more. I hope you can stick around.
I have all the time in the world.
All right. You talked about this briefly, but the person is asking about the Mitrofanov surgery. It is a very major and involved surgery. So they're asking if a suprapubic might be a bit easier as a first step before going through that major surgery.
Yeah, I mean, it always depends what the patient has. I tend to break patients into good hand function, not good hand function. If you don't have good hand function and you're reticent to have a big reconstructive surgery, yeah, an SP tube is great. If you have great hand function and you don't want reconstructive surgery, well, I kind of like the intermittent catheterization idea. As a suprapubic, I think a suprapubic tube always makes doing a Mitrofanov a little bit more difficult down the road. It's not that it makes it undoable. It just makes bladder capacity a little bit less over time. I think just because the bladder shrinks around that catheter so often. So it makes my job a little more difficult, but it's certainly not the end all be all. But yeah, I would never have anyone get bullied into reconstructive surgery by any doctor, because in the end, there's nothing to say that it will go perfectly. There are complications to every surgery we do. And, the complications with the Mitrofanov are not trivial. They're things to be thought about. If they were, foolproof, then everybody would do it, right? But they're not. And I don't push hard. Patients will tell me when it's time. And I don't tell them when it's time unless, again, their health is at risk. But almost reconstructive surgery almost never comes into the discussion when we're talking about health risk. It's more, well, you should catheterize a little bit more, or you should have a suprapubic tube, or you shouldn't leak into a diaper. Those are bad things.
Okay. I've never heard of this, but you may have. Do incontinence clamps work? Are they dangerous?
In the spinal cord injury population, I do not like incontinence clamps. Incontinence clamps are essentially like putting a rubber band around your penis, or putting like a clothespin at the end of the penis. Well, if you can't feel that,
wow,
that could be bad, right? So if you tie a rubber band around your finger, generally I'm going to take it off because my finger really starts to hurt and starts to turn blue. If I don't feel that, I could totally forget that there, and the tip of my finger ends up falling off over time. I've seen a patient tie a rubber band around his penis for incontinence and show up with the end of his penis having fallen off. And it's one of the most horrible things I've ever seen. And I wanted to cry just because I was so sad that it had happened. And he obviously wanted to for the same reasons. I am not a big fan in people who are not sensate of doing that. If you have normal sensation, you can do it. But again, you're probably masking something that's a bigger problem. You might want to talk to a urologist about a better strategy. Usually we have one. The penile clamps are generally for very specific populations. And I tell all my residents that train with me that they should never do that for a spinal cord injury patient unless they've really thought about it very hard and they have a very good reason why they don't have a better way of fixing it.
Yeah, very well said. All right, next
Sorry
question.
for the graphic nature.
I understand that reagent strips give many false positives. In my experience, a fluoride reaction to the white blood cells is a helpful way of differentiating from other causes of feeling bad or excessive bladder spasms. Like keeping speculum cups at home, I always did a clean catch before my physician begins an antibiotic, depending upon the severity of symptoms, waiting 3 days for a culture and sensitivity before starting on antibiotic. I'm not sure what the question is.
Well, I can kind of speak to that a little bit. So, I'm not sure test strips are the best idea because, as I said, I think most people with spinal cord injury always have bacteria in there. There's always going to be some red blood cells. There's always going to be some white blood cells. I don't know of any study that's ever been able to differentiate the degree of white blood cells that can tell you infection versus no infection. This particular questioner may have had really good success with it, and I'm not going to argue. As for waiting 3 days after your culture to start antibiotics if you're really sick, I tell people, look, you can drop off your culture. You can start antibiotics that day if we think you're really sick and you need it. The culture is just to make sure if you're not getting better after several days of antibiotics, well, did we pick the wrong antibiotic? And the other reason is, if you continue to have problems over and over and over again, I can start to see the pattern and figure out, am I missing something else? That's the reason for getting the culture ahead of time. It's not because I'm trying to be a jerk, and I'm not trying to hold antibiotics back from people that need them. I'm just trying to do it in a very academic way. So when things don't go right, and they don't always go right in my practice, I start to have an inkling as to where we're failing.
Okay. Is it necessary to have a CAT scan of your kidneys each year to review with a yearly urology appointment?
My preference is to do something that doesn't require radiation as part of my yearly screening, and that's why I do ultrasounds. I think it's important to do every 12 to 18 months, at least an ultrasound, to look at the kidneys, make sure a stone isn't developing. Most patients with spinal cord injury, if they develop a stone and drop it, they don't come to the hospital because they have a lot of pain. They came to the hospital because they have a UTI stuck behind that stone and they're really, really sick and they end up septic in the ICU. So I like to catch those things before they become problematic and remove them before they become a problem. I don't, a CAT scan is certainly one way to go about yearly screening of the upper tracts, but for the most part, I like to start with an ultrasound. If there's a problem on the ultrasound, I can always go to a CT scan and I don't have to feel like I'm giving a patient undue radiation exposure.
Okay. Does age change UTI symptoms? As an older paraplegic, I don't seem to develop a fever as often as I did when I was younger.
I don't know. It's a good question. I tend to find that as most of my SCI patients get older, they start to have more problems with UTIs and leakage and things like that. I haven't seen it get better for the most part. So I'm not sure I know. I think it's great that this particular questioner does better over time and isn't having severe symptoms associated with the bacteria in their urine. But I don't know of any data one way or the other to answer that any better.
Okay. Next question. I'm an L1 paraplegic and I've used Crede successfully for 35 years. In the last years, I have developed bladder leakage. I have never seen a urologist other than when first paralyzed in 1985. How do I find a urologist in my area?
Yeah, so that's kind of a difficult one. I think Franklin often can help people find a urologist in their area.
Well, this person is in Austin, Texas, so that might be a little bit beyond my level of knowledge.
No, but I think, there are people in Austin at the University of Texas. I know there's someone with the expertise. I had referred a patient fairly recently who was moving to Austin, Texas, who I was doing Botox injections. And I actually referred her to that. I forget her name, but she runs the female pelvic medicine and reconstructive surgery program at UT Austin. So I know there's someone there. I think you just have to find someone who understands your condition and figures it out. So L-spine and S-spine injuries are much more rare than the typical thoracic cervical spine injury. So there are some special bladder conditions that go along with an L-spine or an S-spine condition that should have someone look into them. Because if you get someone that stops your leakage, well, they may also stop your ability to Crede void. And you might have to be thinking about doing intermittent catheterization or something else. So I would be very careful about just going to anyone. You got to have someone who can think ahead about what the consequences of fixing that incontinence might bring.
Okay. Next question. I've had bladder stones in the past removed by you. And I noticed sediments a couple of times a month. I do use Renicedin flush every day, and my suprapubic doesn't get clogged as often. But any other things I can do to help prevent more buildup of these stones?
I think the big things are Renicedin. Like I said, it works pretty well in this particular capacity. Again, it's not decreasing UTIs; it's just decreasing stones. It also it kind of points to the importance of a yearly ultrasound of the kidneys and bladder. So if bigger stones are developing, we catch those ahead of time. I think the only other thing you can try to do to reduce stones either in the kidney or the bladder is really good hydration. When you have a suprapubic tube, you can really push yourself to that 3 liter or plus limit. So because as soon as the urine hits your bladder, it's leaving, right? You don't have to catheterize more. So I usually like my patients to take advantage of that. But I don't think I have anything else. I wish I had better things, because for some of my patients with suprapubic, the incrustations and the blockages are very problematic, and they're quite vexing for both the patient and myself. Very frustrating part of the suprapubic. It's one of the hidden problems of suprapubic tubes.
Okay. This next question, when someone suspects that they have a UTI, they leave a sample for testing, their doctor gives an initial report within a couple of days that discloses the presence of bacteria. Then it takes another week to get, a report of the strain and the appropriate antibiotic for treatment. Is there another test or type of urine analysis that can give the results much faster?
So typically that's not been my idea of what the timeline is. Typically within, at least at our hospital, within 24 to 36 hours, we know the bacteria, and within another 12, we typically have the antibiotics. So usually within 48 to 72 hours, I have the full report. I don't know if this is just a particular lab that's a little slower than others. I don't know if maybe it's just the doctor taking a little bit longer to get the results out. There are companies working on DNA or RNA testing to diagnose the type of bacteria and come up with antibiotic sensitivities more rapidly. It's an emerging technology that is not perfect yet. It's almost a little too sensitive at times, because they find, I think, almost too many bacteria in my mind. And it leads difficulty in knowing what to do with 6 different types of bacteria in your bladder, like which ones do you treat? But there are companies out there trying to come up with even faster platforms. There are people that have been working at the Palo Alto VA, Joe Liao for one, for 10 plus years on trying to develop chip-based things where you put a little bit of urine on it, and within 20 minutes to an hour, you have everything. You know the bacteria, you know what it's resistant to, you know what it's sensitive to. Those have not, they haven't been commercialized yet, and I have to assume there's some problems, and it's not as easy as it was once thought to be. But I do know companies are continuing to work on that technology, but I can't tell you anything that's any faster right now.
Okay. And your sort of approach is one of sort of starting the antibiotics, maybe some generic sort of general antibiotics sooner rather than later, right?
If a patient truly has a UTI, like they have a fever, they have new onset leakage, or there's something really wrong, more often than not, if I really think it's serious, I'm going to treat them ahead of time. If I have some reticence, then I'm going to wait for the culture. But it depends on the situation. It also depends on when a patient catches me in the day. There are some days that are better than others. There's some days where my nurses will just do everything, and I'm not even in the clinic because I'm in the operating room. It's hard to be a surgeon and a clinician, and it's hard to be on beck and call. So often I like most of my spinal cord injury patients to go through their primary care or someone else who can respond a little more rapidly than I can at times. It's just I wear too many hats at certain times. But yeah, there are times where I will start the antibiotic absolutely. As soon as you drop off the culture, you can go pick up your antibiotics. There are other times where I like to wait a day or two to see what we're dealing with. And there's sometimes I'm not even sure I really need to treat, but I want to see what the bacteria is, because it could be like if we're talking about incrustation of a suprapubic tube. Well, if it's happening rapidly, and I know it's a certain bacteria that can cause it, well, I'm not going to start treating with antibiotics till I actually know that they have that bacteria. So some of my patients listening, you may get like, well, why doesn't he do that for me? I promise there's real methods to my madness. But yeah, if I think somebody has a real problem, yeah, I'm going to start antibiotics right away.
Okay.
But again, it depends on the person. It depends on our history. It also depends on what I perceive to be the level of the problem. And again, I will admit that sometimes I perceive a problem not to be nearly as bad as it may be to the patient. And if anyone's out there and they're mad, I apologize. I'm not trying to treat
No
people.
need to apologize, Chris. And I have good news for you, because that goops was a typo. So no need to look for it.
Okay, I won't look that one up.
Yeah. Next question. I'm allergic to Bactrim, which was used to treat Staphylococcus cocoa, whatever bacteria in my bladder. Is there an alternative antibiotic, oral antibiotic that could treat this?
Yeah, generally there are. Obviously I'm allergic to Septra as well, sulfa-based antibiotics, so I can't take those either. Yes, generally if you have a staph that's causing a problem, generally there's several other antibiotic choices that you can take by mouth, whether it's ciprofloxacin, whether it's Keflex, whether it's nitrofurantoin. Generally there are other options, yes.
Okay. I had a resistant UTI a year and a half ago. I've been UTI free since. How concerned should I be that my next one could be resistant again? I take Hyprix and it has done wonders for me.
I would say resistance is just luck of the draw. The more you take antibiotics, the larger chance you have of resistance. But I have some people that have resistant antibiotic that have bacteria that are resistant through who knows where they actually got it. It could have been from their food. It could have been from their environment. We don't know. I also have people that get UTIs all the time and they continue to be sensitive to most every antibiotic. So again, that's the importance of getting the culture before actually starting antibiotics so that we can figure out if things aren't getting better, why they're not getting better. But if you've been UTI free for a year and a half, I would not let a past UTI dictate my future fears, my future thoughts of what I might get. I wouldn't let it, change anything that I do on a regular basis. And honestly, I wouldn't think about it that much because clearly you don't get infections very often, which is fantastic.
Okay. If you have full sensation, do you feel it's okay to use a clamp on a suprapubic instead of a bag?
So yes, I think even if you don't have sensation, I think it's okay, but it has to be under a doctor's supervision to tell you what's good and what's bad and what you can do and what you can't do. But no, I don't think that clamping a suprapubic tube is bad, but unless I know that person's exact bladder parameters, I can't develop a program for them to do it. And it's not always based on sensation. Sensation, sometimes when people feel things with spinal cord injury, it's way too late. And sometimes it's just time to empty. It's very individualized. So it's a tough one, but no, I don't think that clamping a suprapubic is bad when done with enough data to make a good recommendation of how it should be done.
Okay. How common is hydronephrosis?
Hydronephrosis. Hydronephrosis is not a great thing. That generally means that there's something anatomically or physiologically affecting the kidney, that it's not draining under optimal conditions. Hydronephrosis is one of those things we see in bladder management, and that generally can mean that the bladder is under high pressure and it's starting to transmit those pressures to the kidneys, and hydronephrosis is one of the ways that we see that on imaging. However, there are some types of hydronephrosis that are not dangerous at all, and they've been there for a long time, and we do studies and we realize that it doesn't matter, but it's very individualized and you need a urologist to kind of understand all the parameters to tell you if you should worry about it or not. Other times hydronephrosis can be because you dropped a stone and it's now blocking your kidney and you've got all that extra fluid backed up. Again, it can be a multifactorial process, and it's more so, it can be a bad thing, but it can also be a thing that doesn't matter. And it's tough one to answer.
Okay. Next question, as a person with a suprapubic, what is it best to insert the solution, then draw it out several times, or leave it in to drain out on its own? Is it safe to reuse after washing the syringe?
Yeah.
The sterile water, saline, vinegar, and some water solution or other fluid best?
Sure. So good question. For some people that are getting lots of sediment or incrustations, I think, trying to pull in and pull out is fine. For other people that don't have those problems, just putting it in and then letting it passively drain out 20 minutes later is fine. As far as reusing the syringe that you put it in, I only write people for 2 per month when I, administer that type of therapy. So I always feel that people's bladders are chronically colonized anyway with bacteria. I don't feel the syringe is going to add any sort of problem to the regimen. So no, I think reusing them. If you really want to be fastidious, you can clean it with some soap and water or like a 1 to 10 bleach solution, but I don't think it's necessary. So I hope that answers your question.
Okay. Physicians seem hesitant to prescribe Ditropan as I age. Is there science behind that?
Well, it's kind of a little bit of controversy, but not a ton. There's some growing evidence that in people with new onset dementia or kind of pre-dementia, that anticholinergics may make their thinking a little bit worse. There may also be some data, though it's very, very, very controversial, that taking drugs like oxybutynin may lead to dementia, but I don't think we really have a very good handle on that. So I have not changed my practices to date. But there are doctors out there, especially ones that don't prescribe them on an everyday basis, that are read the headlines and don't really understand the data and are becoming more and more reticent to use those drugs. Again, we measure these things with things called odds ratios, and they say, well, you might be slightly higher than the general public to get X, Y, or Z based on an odds ratio. But sometimes the risk of those diseases are so low, even if you have an increased odds, it may mean nothing, in terms of absolute risk. And the studies that are being done on these drugs are not perfectly done. And again, the effect sizes are very small. So it's very difficult to interpret the data. There are alternatives to anticholinergics at this point, like beta-3 agonists, so like Myrbetriq. So for some patients, those are the right drugs. There are also formulations of anticholinergics that have been shown not to cross the blood-brain barrier, so theoretically should not lead to dementia and things like that. That drug is called trospium. So there are lots of options out there, and I don't know if I have enough to say, no, you should stay off anticholinergics like oxybutynin and Detrol, and I don't have data to suggest that maybe that's the best choice for you. It's a very individualized discussion with most patients, and I tend to run these things very quickly in my head as I see patients and decide. But it's an ever-changing kind of target on that particular one. So my advice to the audience would be, don't overthink this one yet. Don't get alarmed yet. We don't have very strong data, and I have not changed my practice patterns.
Okay. All right. Promise this is the last question.
Okay, that's fine.
That's an easy one. Is suprapubic permanent? We know it's not, but how complicated is it to reverse it?
Suprapubics to reverse, the hole itself, if I take a suprapubic out, the hole closes in 24 hours. It's gone. You might have a little indentation for where the tube went in for whatever amount of time you had, but there's nothing permanent about it. If you've had a suprapubic for 20 years and let it drain to a bag, trying to transition over to something else like intermittent catheterization can be a little more difficult in terms of regaining that bladder capacity. It can be done, but it takes time, and we all don't like to wait, especially if we're leaking in between and things like that. But it can be done under a urologist supervision. I've transitioned several patients from suprapubic tubes over to intermittent catheterization. But an SP tube, for all intents and purposes, is reversible. So if stem cells come around someday and they cure all spinal cord injury, and I would love it to have each one of my patients come in, dance in front of me and say, I don't need you anymore, and walk out of my office, that would be fantastic. Should it happen, the suprapubic can be removed and a patient could go back to volitional voiding long term.
Okay, so I lied. One last question.
That's okay.
Botox use in kids, when to use over medications?
That's a tough one because I don't know if we have great data one way or the other. Botox works beautifully. Medicines work very well. It's a very individualized decision. I'm not sure I would advocate for one more than another. I typically will start with medications just because I find Botox somewhat invasive, especially in children. Their anatomy is smaller, so trying to get a smaller scope or trying to actually inject the medicine can be a little more difficult. If you have to put the child under anesthesia every time we do it, I don't know if putting a child under anesthesia twice a year to get their Botox injections is the right thing to do. In adults, I think I have more leeway because I can do it in my clinic, and if they get horrible autonomic dysreflexia, which almost happens maybe once every 5 years, then we would deal with it in a different fashion. And typically I already know they're going to be a problem before I even do them. Because of other tests we've done that have led to autonomic dysreflexia. So what's the right answer? I don't know. It depends on the size of the child. It depends on how they're going to administer the Botox. It also, depends on the patient and the parents. Do they really think some harm is going to come from chronic use of a drug? But I don't think getting Botox, long-term never been shown that people develop resistance to it or causes like structural changes to the bladder. So I don't see a downside in doing it. There may not be as much of an upside.
Okay. Chris, I can tell you, I've never had this many questions asked of one of our speakers. So kudos to you. You have won the prize.
This is great.
And also equally, I've never had so many people who've been grateful and have actually sending their sincere thanks to you for sticking around for as long as you did to answer all these questions. So
I'm totally happy to.
I've thought of you for long time, ever since I met you several years ago. Very highly, a very capable, competent, experienced, compassionate urologist, and really appreciate you spending the time to answer as many questions on this very complicated and, like you said at the beginning, poorly researched kind of symptom or secondary condition of a spinal cord injury. And it's frustrating because there is no 100% accurate answer on everything. There are so many variables, and we understand that. But nonetheless, thank you so much for breaking it down in sort of in terms that we all understand and comprehend. There is one person, and I just want to mention, Cindy had a very long question. Cindy, I'm going to approach you offline separately, and I know Chris would be more than happy to answer your question. But if I read it, it'll take me probably 10 minutes. And I want to make sure that we give her appropriate amount of attention and time. So we'll do that offline at
absolutely. And you can shoot me an email anytime, Franklin.
I will. Thank you so much, Chris. Thank you so much, everyone, for hanging on for the 90 minutes. This was very informative. As I mentioned at the top of the presentation, we have recorded this presentation, so you'll all get a video recording link by this weekend. Have a good night, everyone, and thank you again, Chris. Really appreciate your time.
No, it's my absolute pleasure. Like I said at the beginning, one of the best things that ever happened in my career is I came to Santa Clara Valley Medical Center, and they told me I was going down to the rehab clinic and I was going to see spinal cord injury patients. And I knew a little bit, and now I know a lot more. And I still know, I wish I knew a lot more things, but it's been one of the great parts of my 8 years here, and one of the more satisfying parts of my career to take care of those with spinal cord injury. So thank you for everyone that was on. I'm always happy to help.
Well, in my 31 years since my injury, you are the best urologist I've ever encountered, that I've had the opportunity of listening to and learning from. This was highly informative for me. I know that. So thank you again, Chris.
All right. Well, everyone have a good night.
Okay.
Bye-bye.
Good night, everyone.